Good afternoon, everyone, and welcome to our 3D Point of Care webinar today. My name's Emma Webster, and I'm the UK Sales Manager at Materialise, and I will be your moderator for this session today. And we're going to have some really interesting and thought-provoking insights from the University Hospitals of Leicester on how to successfully implement and develop a 3D service within a teaching hospital. And we've got the team from the Leicester Royal Infirmary with us, and also the Leicester Glenfield Hospital. And these teams will be sharing their experiences on how to integrate and expand 3D technology within a hospital to develop optimal and predictable patient care. So a little introduction on what you can expect from this webinar this afternoon. The presentations from the faculty will have a duration of about an hour. And I really urge you to use this Q&A session, which will be after the presentations, to ask the Leicester teams anything related to point of care 3D planning. And it's a great opportunity to gather their expertise and input and to find out more about how it could add value to your institutions. So just a reminder that the webinar is being recorded if you'd like to listen to it after today, and will be available later on our website. So just to point out, the chat box here is where you should be posting your questions that we will then take into the Q&A session after the presentations. And Materialise are part of an exciting healthcare shift. We're seeing access to 3D technology increase significantly, and globally we're seeing an increased adoption within hospitals and clinics who are setting up their own 3D planning and printing facilities at the point of care. And this brings new opportunities for clinical teams and physicians to be able to deliver more personalised care and increase patient satisfaction. And we work with hospitals every day to help them achieve their 3D printing vision and realise its benefits both at the clinical and operational levels within their institutions. So, a very warm welcome to the University Hospital of Leicester, so Leicester Royal Infirmary, Maxillofacial Department and 3D Laboratory. I have the pleasure of introducing Mr. Matt Pilley, who is a specialist in clinical prosthetics and also the department manager, and his deputy colleague, Graham Marshall, who's the clinical prosthetist, and they're going to be presenting their experiences shortly. Thank you.
Right, good afternoon everybody, and welcome to our overseas people. I believe some of you are listening to us in America and various other places beyond too. Hopefully this webinar will show you how our 3D print service has evolved and progressed, and the functional value it represents to our patients, our surgeons, and most of all, our hospital facility. So, why implement a 3D printing service into your hospital? There are many reasons, really. 3D technology within healthcare is expanding massively and has done in the last few years, and will keep on continuing to grow and grow. It improves patient care and outcomes, hopefully. It helps with the increased planning complexity of personalised medicine, which is now becoming a big buzzword across the world. So, implementing 3D printing into your hospital, as I've just explained, 3D within healthcare is massively expanding. The real reason that we implemented it here was to reduce the reliance on external bureaus and medical device companies. For a couple of reasons. One, because of the cost involved, we can do things cheaper in-house, and also we've got total control in-house. We're not waiting on things being posted or transmitted down various routes of technology. So we've basically got our finger on the pulse. And as it proved, one case, our surgeon came in the day before an operation and said that he'd like to have a ProPlan case for this particular patient. And we managed to pull it out of the bag and get everything delivered and ready for theatre at 9 o'clock the following day. If we'd have been reliant on an external bureau or medical device company, there is just no way that could have happened, because they probably need at minimum a 10-day turnaround time. So the next thing you need to think about is how you are going to fund this 3D printing software and hardware. Many of us have very small budgets if we work in the health service in the UK. So sometimes it's a good idea to look at whether you can use other people's budgets and pool them with your own to try and increase your revenue or increase your funding pocket. Hospital innovation schemes are out there, technology schemes. Sometimes you can get funding from those. Normally within hospitals, you're looking at a couple of routes, one being charitable donations, which normally is a long, hard slog. Or the way that we managed to eventually procure this equipment was through a capital bid. And once again, a long, hard slog over 3 years, basically convincing the powers that be that this was going to help them, help the patients, and help the surgeons to improve patient care. So how do you work out the value to your hospital? So you've got the patient value, first of all. Improve patient satisfaction because they can make informed choices by researching their options. So some patients actually come in and say, I've read about 3D printing and stuff. Is it possible that I can have something like this done for my operation? A lot of surgeons say that it's really valuable to be able to show the patient a 3D model of their particular problem so that they can understand much better than if they were looking at a CT or a scan. That way they can understand their surgery much better, and that way they can make a much better informed consent. And also one of the positives as well is that virtually all of our surgeons are convinced that it reduces time under general anaesthetic. In theatre, this results in reduced theatre time, fewer complications, hopefully reduced infections and failure rates because things are a lot more precise, planned. And as one surgeon said, by the time I go in and do the operation, I've already planned it once virtually. And also this can work out in a reduced hospital stay, which again, the trust are really keen on because again, it's saving money. The big thing for the trust is the reputation of using latest technology. They like to be able to compare themselves and benchmark themselves against other hospital trusts. And if they're using the latest technology, then it's a win-win for them. Also, it eventually reduces expenditure to external printing companies, because before we had our own facility, we were sending a lot of work to external bureaus. It helps in staff training and development, and sometimes if you start printing for other hospitals, it can also provide a revenue stream. So you've decided you want to go down the 3D route. Next, you need to work out what software you want. What are your requirements? What are you actually hoping to produce? And that will give you some idea of the kind of software that you require. Please bear in mind that you need to be using CE mark products, especially if you're in Europe and the UK, because of new MHRA regulations that are coming in next May. And at the moment, the only one that fits the bill in terms of segmentation is Mimics from Materialise. And if you get the whole Mimics suite like we have, you've got Mimics, 3Matics and ProPlan. Tie that up with Object Studio that helps run our 3D printer. And then you've got a very good, complete system in which you can operate. We first of all opted for a 3-year deal just to make sure that we could prove that our print service was up and running before we had to go and ask for more money to secure another license deal. We've now just done that, and we've now just secured a 5-year software option deal. Your printer and hardware selection, again, is very dependent on what you are hoping to achieve. We were hoping to basically provide a service to most of the departments within our trust. So we opted for something with a large build size table. We opted for a fairly easy printing technology. We also need to think about material options and their costs. And also, one of the big things, if you're going to be producing cutting guides, is you need to be able to produce stuff in a biocompatible, autoclavable material that can go to theatres. Printing speeds and printing accuracy are obviously important things to think about, along with whether your printer is certified and accredited, whether it's STL compatible. And then you need to start thinking about how you're going to clean your models off when they come out of the printer. And lastly, the big thing that every hospitals and facilities hate is maintenance contracts. Can you do some of the maintenance yourself, or do you need to opt for a proper maintenance contract? This is our evolution timeline of our 3D experiences. So the biggest thing was obviously the printer and software arriving in 2017. Before that, we'd been very dependent on outside bureaus and agencies. Not long after we got our printer, we started working with the team at Glenfield, Saravanan and Greg, producing our first heart prints and patch template guides that were very important for the paediatric cardiology team up there. We then did our first ProPlan case, our first 3-matic design titanium implant. We then did some further charity bids to get a more improved support material remover. We've then done some more 3D printed implants, and soon we will hopefully, be looking at moving on to orthognathic, because we just had a change of surgeons, and hopefully that will be the next move forwards. So what are the benefits to our teams here? The maxillofacial have benefited greatly from our 3D printing facilities. Trauma cases, oncology reconstruction. We've done a couple of orthognathic surgery cases, more as test cases, but hopefully we're hoping to expand that in the near future. Bespoke prostheses, we can use it to flip and mirror scan data to produce things. And also we've used it for the production of burn splints. So all in all, it's very, very useful for the maxillofacial specialty, and that was ultimately why we went down this route. The prosthetics and software use is really, really good as well, because you can get models scanned, import your STL files, mirror your data. Once you've mirrored your data, you can then export your STL file, print out a model, which gives you an exact replica of the contralateral digit, hand, ear, or half a face. You can then use that to then make a mold, and then from there you can make a wax pattern. Now this all sounds fairly straightforward, and the major benefit of this is that patients psychologically are a lot more accepting of their facial prosthesis or their hand prosthesis, because they see it as it's been produced from their own anatomy. It's an exact or near as exact copy of their existing anatomy, and so they have a bit more ownership of it than if it was taken from either a donor hand or something that we've carved from scratch. Patient-specific implants. This is a case that we did for a congenital problem due to bladder expedasis. We designed the implant in 3-matics, working with a plastic surgeon and an orthopedic surgeon. You can see here we've made some screw and drill guides. We've then produced the implant. We've sent the STL file away to an external bureau because unfortunately we don't have the facilities here to print in titanium yet. There's always hope though. Imagine the capital bid for that one. And then here's the final X-ray with the implant in situ. Unfortunately, I can't show you the photos of the patient because he didn't consent to them going on the World Wide Web, but he did consent to this lot being shown. You need to record all your data because this is how you go back and prove that your 3D printing is adding value to your hospital, to your surgeons, and to generally your patients. So we've got a very simple model request form, captures everything that we need. We can then use the data for audit purposes. It's really handy when you want to upgrade things like your software, the license needs renewing, you can go back and prove how many cases you've done. It can show you cost savings and also shows who's using the service, who are your end users. Is it just MaxVac? Is it orthopedics? How much is the percentages? So that leads nicely into the next slide. So here's just a little audit we did of the first 3 years. As you can see, in the first year, MaxVac did not use us at all. And the reason for that is the department was going through massive changes with the old guard retiring and the new consultants coming in. And so basically a whole year went by where they never used the printer at all, basically due to massive changes going on within the department. You'll also notice that medical physics that used us quite a lot in the early days now don't use us at all. That's not because we've had an argument or fallen out with them. It's purely because they've managed to inherit themselves a little FDM printer. So if anything needs to be a little bit more precise and needs to be biocompatible, then they come and knock on our door. But if not, they tend to try and print their own stuff. As you can see, we've done a fair bit of printing for external people, other hospitals mainly, and some private companies, but that's not really the aim of why we've got the stuff. It was really to help all the other specialties. And as you can see, cardiology up at Glenfield have been pretty steady across the board, not masses and masses because they are expensive, but we have produced a fair number. So this gives you a little idea and a little sample of some of the things we have printed over the years, from the orthopedics to the pediatrics, cardiology up at Glenfield, and then to the medical physics. So some of this has been used for research and various patient testing. And the phone case wasn't to keep my mobile phone safe. It was part of a diabetic research program where patients had these inside their pockets and they couldn't work out why the kids that had them were smashing them at such a high rate. So they produced these super strong, indestructible iPhone cases. Obviously, as we all know, we've been through a rather nasty pandemic and it is still carrying on, but we had the director of operations on the phone and the director of productivity asking us, could we use the 3D printer to help them out and produce more face visors. So we had to fulfill various criteria from infection prevention, but we produced a large number of these visors with a soft insert because we have quite a flash printer that prints in different materials. So they've got a soft insert at the front, and then we were asked to produce some visors that allowed surgeons and nurses to wear loops underneath, so we had to extend them, make them a bit bigger. And then we also printed some of these masks, snorkel mask adapters, but fortunately these never had to be used in the end. So thank you for your attention. I hope I've given you a bit of an insight as to how you can capture your value, how you can prove to your trust. If you haven't got a 3D printing system set up at present, keep a record of all the stuff you're sending out, what it's costing you to send out. At the moment, we have worked out that in the last couple of years, we have saved on average about £80,000 in the fact that we haven't sent cases out to external agencies for things like ProPlan and patient-specific cutting guides and stuff like that. So that pretty much alone pays for the software each year. So I'm now going to hand you over to Graham, who's going to go into a little bit more detail about some of the stuff we've been up to in the maxillofacial world. Thank you.
Thank you for that, Matt. So I'd just like to share our experiences of how we use the Material software suite on a day-to-day basis. We've been using it for the past 3 years. And the software that we have is made up of Mimics Imprint, which turns your ICOM data, your CT data, into your SDL files. And then in the middle there, we've got ProPlan, which is the virtual surgery package, so you can plan your surgery. And then the design package, 3Matics, so you can design all your cut guides. Matt says our aim was to offer a 3D planning system for the maxillofacial department and then roll it out to the rest of the university hospitals of Leicester. So that was our aim. And for this webinar, we're going to show examples of mandible resection and fibula reconstruction to show you how the software interacts with each other. So this is the development. In 2017, we did some orbital floors for MaxFac and pediatric cardiology and the phone cases that we mentioned earlier. The big breakthrough was in 2018 when we did our first ProPlan. It was a fibula case, so we did resection guides to the mandible and a corresponding fibula guide. Also with the ENT, we did some implant planning for a rhinectomy patient, and then started doing 3D printing for other hospitals. In 2019, orthopedics and ophthalmology came on board for models and for the ophthalmology with the implants, with the custom-made titanium implants. And in 2020, the aim is to introduce the digital orthognathic service. So straight away, when you get the software, it opens up so many doors. Straight away with 3D models, can be something as simple as a conformer for a rhinectomy patient. In the middle of your screen there is a trauma case, so we can reduce the fracture just like the surgeon would to mimic it, and then we could pre-bend the pet plates, and the orbital floor would then restore the orbital volume. The SDLs would go into the packages to ProPlan and into 3Matics. We've got the orthognathic that we're going to go down, pre-bending the plates on just for a simple mandible recon bar. And at the bottom there, we've got your head and neck cancer work, whether it be fibula, DCIA, or scapula. And then you can create the surgical cutting guides. And when you get a bit more experience, you can create your own patient-specific implants. So this is how the software fits into the patient cycle. So it all starts with a planning request form from the surgeon, and then that information goes into Imprint, and that then turns the DICOM into SDLs, and then those new SDLs can go into ProPlan, which is your virtual planning software. And that generates new SDLs, then it goes into 3Matics. And that's where you design your cut guides, and then they can be printed in Med610 and sent off for sterilisation. We do have to allow extra time for sterilisation because it's now off-site. So we do have to build in 1 to 2 days for that to be sterilised. And then ready for the surgery. And all this planning will reduce the theatre time, anaesthetic time, and give a more predictable result. So the first thing we did, we designed a capture form. So the one on screen is the ProPlan form. We've got 3 forms. We've got one for a simple model, one for an orbital floor, and one for a ProPlan case like this. just with some information about what's going to happen. So the patient sticker, most important one on there is the MD number. So this will stay with the patient throughout. So as soon as we get it, it gets booked in, and that will go onto the model. It will go onto the sterilisation, and it will go into the patient workflow, which is then put into the notes. We always record what type of CT we downloaded and the threshold value, and then the information that you need, mandible, maxilla, and what type of operation. When we have the planning session with the consultant, it has to be signed and dated by the consultant to show that he's agreed the resection margins. So you've got your information, and then you need to get the DICOM data. So in the early days, this was very difficult. We used to have to go to radiology and they put it on a CD, but then they'd say, Graham, it's not working, or we're on holiday and we can't do it. So then we came across Universal Web Viewer, which you can download direct, and that's really revolutionized how we get hold of the data. So it's always there when we need it. So from there, we create 10 folders, just 1 to 10, and follow that flow through. And they're all stored on a backup drive. And then you're ready to go into the first package, which is Mimics Imprint. So this is Mimics Imprint. It's a brilliant package. It's a wizard-based package, and you just run across the tiles there from left to right. Start with your thresholding. We always try to do the same thresholding if possible. Stick to the presets of bone CT, and then you can segment out what you need. So whether you need the fibula, the mandible, the maxilla, whatever you need, and calculate your part. It really is a very good package to use. One of the great features of this imprint is this split facility. So just say you want to split the mandible from the maxilla. It's got a foreground which you just paint over. So that's the area you want to keep, and the area you want to erase is the background. And then just hit the button, and on the screen it just splits it for you. We always do a check STL for a fibula case, so we'll do both legs, left and right STL, to make sure at the end when we do a double check and Matt checks that we've completed it on the right leg. So that will generate your STLs, and now those STLs are then ready to go into the next package, which is ProPlan. So this is your virtual surgery program. It is a wizard base. It does have various different wizards. We use the fibula one the most, but we will be using the orthognathic one shortly. So the first thing is to import all the STLs from your Mimics into ProPlan, and then you are ready for the planning session with the consultant, and he will tell you where he wants his cuts to be placed, and as you can see on screen with the osteotomy lines, and then at the bottom the red is the segment that's going to be removed. One little thing we did learn is to label up the fibula. So on the anterior of the fibula we label it up AAA, TTT, KKK. So A is simply for ankle and K is for knee. This is important for the pedicle direction. So then you simply put your points. This one's a 3-part fibula, and because it's a wizard-based system, the computer puts it onto the fibula for you. So you put your 3 points, and then you do all your movements before you tick on those osteotomy on the right-hand side of the top of the screen. You don't want to tick that on until you've done all your movements. So you go 8 centimeters, well, we go 8 centimeters from the malleolus, it might be 7. And then we make sure that the lateral portion is on the buccal of the mandible, and this helps us with the marking up. And at the bottom right of the screen, this one is showing that it's a posterior pedicle. Then you are ready to enter into the design package, which is 3 matics. So these are the mandible cut guides at the top of your screen. We leave them larger to start with, and then we'll finish them off when we do the reverse engineering. And also we do now put a handle on them, a removable handle, which helps with the position of the guides, the anterior-posterior relationship of the guides, because you want these guides put in the correct place. And at the bottom of the screen is the corresponding fibula cut guides. That also has a removable handle, which will help with the location. And also we mark them up, because when they come back from sterilisation, that'll all be messed up, so that we know which one's the ankle and which one's the knee. We print it all in Med 610, which can be sterilised. They sit 1 millimetre away from the tissue, well, from the bone, and we always fix before we print the file, so you've got a signed file to print. So this is the finished result. Then you have the option to pre-bend the bar, which will save the fit on theatre time. And on the right-hand side, it does have Through-Matics does have a wizard-based system where you can create your patient-specific recon bar. Just want to tell you about endpoint registration. This will help save ischemic time in theatre. So this is just about simply putting the recon bar on the leg first, and endpoint registration can help you with this. You move the purple segment back to where it was and punch the holes in the fib guide, and this will enable the surgeon to precisely place the recon bar onto the leg, so the flap can stay connected longer. Also, endpoint registration came very useful a couple of months ago. The surgeon didn't have enough time to reconstruct. He wasn't given that luxury, so he did a resection first with a delayed reconstruction. So number 1 is the resection, and number 2, the pink and the blue. So the pink is the start scan, and the blue is how the patient was after surgery. Then you do an endpoint registration, number 3 on the skull, and number 4 shows the difference. So we still need to move the mandible to the start mandible, and there's the result on number 5. This obviously puts the patient back into the correct position, and the aesthetics and function will be restored with a fibular graft. This is something we're working on at the moment. It's a soft tissue for our fibula patients. So it's 8 centimeters. This one on screen is 8 centimeters from the malleolus. So this is used pre-surgery. So when the surgeon's marking the patient up, and he knows accurately where to place the fib cut guides. Every patient that goes to theatre gets some A3 laminated sheets for the theatre wall. It shows about guide placement and resection margins. And the one at the bottom there, the pedicle length. So this being a 3-part, they need as much pedicle as they can. Every patient also, for the notes, gets a summary of the workflow of what went off. The end page there has the MD number on, has the sterilisation code on, and the lot and batch number of the cut guides, and then is signed and placed into the patient's notes. And these are just some comments from our surgeons about the service over the past 3 years. A couple from our MaxFat colleagues, and an ophthalmologist, and some orthopedic surgeons, and some plastic surgeons. And that's our boss, Hazel. So she's kindly made some nice comments there. So what I would say, it is a learning curve. We have learnt loads over the 3 years, and we will go on learning every day with it. So thank you for your attention.
Thank you very much to Matt and Graham for that really interesting presentations there. I think it's amazing to see the journey of your 3D facility and all the applications where you add value. So thank you for that. And it's also great to see how, when you're using the software, those tips and tricks you showed us, you've obviously evolved that kind of skill level over time. So yeah, really nice to see. And again, just to remind the audience, in the chat box, please, any questions that you have, you'll be writing them in the chat box, ready for our Q&A session. So thank you. I would like to now have the pleasure of introducing the clinical cardiology team from East Midlands Congenital Heart Centre. So you have Mr. Branko Mimic, who is a consultant congenital cardiac surgeon and the surgical lead. We have Dr. Greg Skinner, who's a consultant paediatric cardiologist, and Dr. Saravanan, Durairaj, beg your pardon, consultant paediatric cardiologist. So I will enable them to have control of the screen for their presentation. Thank you.
Thank you very much, Emma. So I'm delighted to join you. We're going to talk about our experience at the Congenital Heart Centre with 3D printing, which we've been able to implement over the last 3 or 4 years. When we're quite excited about this technology, we think it adds a lot to us. We don't have any disclosures and would like to thank the rest of our team here at Glenfield Hospital in Leicester. Just a brief warning for people that our presentation will contain pictures of real cardiac surgery and anatomical specimens from children. So if you find that you won't be able to tolerate that, please switch off now. So I'm going to go through about why we use 3D planning for congenital heart surgery, talk a little bit about the process that we go through for modelling. Then I'm going to hand over to my colleague Saravanan, who's going to talk about how we've implemented that at our centre. And then we'll hand over to Branko, who'll give us the perspective from our surgeons, who are really our end users, and also show you some examples of some of the cases where we have used 3D planning. So why do we use 3D planning? Well, we deal with quite a lot of children at our centre. About 1 in 133 babies born will have some form of congenital heart disease. These defects vary a lot in their degree of complexity, and most of the defects that we see are operable. And our aim is always to try and get 2 pumping chambers connected to 2 outlets to the body, and the 3D planning really helps us with some of the more complicated cases to achieve this. This is a normal heart where you can see that the blue blood that has been around the body and has had the oxygen taken out of it comes into the right-hand side of the heart before being pumped into the lung arteries. After the blood has passed into the lungs, it has oxygen in it and becomes pink, and passes into the left-hand side of the heart where it gets pumped out of and around the body. Here we can see that the 2 sides of the heart are completely separated from each other, which is what we're aiming for. One of the conditions where we have found 3D printing to be especially helpful is a condition known as double outlet right ventricle, and you can see a diagram of this here. The key features are that there is a hole in the heart, and both of the lung artery and the body artery are coming off the right-sided pumping chamber. Our job is to try and get the left-sided pumping chamber to connect to the body artery and the right-sided pumping chamber to connect to the lung artery in order to achieve a normal circulation. This picture is very nice in that it demonstrates the problem. However, this vastly simplifies the complex 3-dimensional nature of this condition. This is a real specimen from a patient who had double outlet right ventricle. We can see the body artery here marked A for aorta, and the lung artery here marked P for pulmonary artery, are both coming from the right-sided pumping chamber. But I think you can appreciate that the anatomy is a lot more complicated than the previous flat image was able to demonstrate. And this is even more real life. This is what our colleagues in theatre have to deal with. You can see the size of the surgeon's finger here in relation to the size of the heart, and you can see the very small opening through which they have to try and correct these very complicated lesions. We perform a lot of three-dimensional imaging in our department to try and establish the exact anatomy of the hearts. This is a CT scan, which basically takes slices through the heart and puts them together. Although this information is three-dimensional, it is presented in a two-dimensional manner, which makes analysing it and getting the impression of the real 3D anatomy somewhat difficult. We can take this data and reprocess it in various ways. This way we have created new slices through the data to try and establish the relationships. But again, it's very difficult to get the overall feel of how things look in real life just using this technique, which is essentially still two-dimensional. We do have some other methods of creating a three-dimensional anatomy, such as 3D volume rendering, which is a basic way of demonstrating the anatomy of the heart. Here you can see a heart where, again, we have the two arteries coming off the right-sided pumping chamber, which I hope you can appreciate. But this is actually just showing where the blood is. It doesn't show where the actual heart muscle is in relation to it, and that's what the surgeon needs to know in order to do their corrections. For this reason, 3D modelling allows us to create detailed models of the actual anatomy which the surgeon is going to encounter in theatre, and allow us to predict what the repairs are going to be like. Just to go through how we plan, this is our segmentation process. We start off with the CT images you saw before, and using the software, we assign values to all the areas of blood within the image, showing each of the different anatomical structures. Hopefully you can appreciate this. What we then have is we have all these chambers of the heart, and this is just the data from the blood. So this is showing us where the blood is. What we need to do is we need to take this model and then translate this into the opposite so that we can see that these blood areas are empty and the solid muscle areas represented by this green area here are solid for our model. This involves creating a hollow model. So what we see here on the video is we take this data from the blood pools, we take the information with the heart muscle, and we thicken it and turn it inside out, which basically leaves us with a hollow model, leaving us with the actual structures of the heart as you would see them in real life. Here we cut open the heart virtually. We can say we take these off, and then you can see inside this is a very detailed model of exactly where all these structures are within the heart. We can see where the body and lung arteries come off from the right side. If we turn it around, we can see where the hole in the heart is in relation to those structures. This provides very useful information for the surgeon to really visualize. And here we see we're planning how we're going to repair that by putting a patch to direct the blood flow into the correct vessel. What we do then, which is a very important stage, is we do what we call reverse validation. So we re-import the model that we've created back onto the CT scan to verify that all the information that we've obtained fits precisely with the original CT scan, to make sure that during the segmentation process we have not introduced any errors and that all our measurements are going to be accurate and precise. What we then do, we often use just the computer model for planning. However, quite frequently we will send our data over to Matt and Graham, who very kindly provide us with these beautiful 3D prints. These allow us and our surgeons to get a real grip of the heart, look from all the angles and see exactly where we're going to do the operation and how we're going to plan it out. This model was enlarged by 2 times to get a better feel for the exact position. However, we normally create our models at 1:1 scale in addition, so that we can see how things are going to be in real life. Here are just a few more examples of some complicated hearts which we have created prints for. This heart is actually back to front. We can see that the apex, or the pointy end of the heart, is facing the wrong side of the body. This is associated with several other complicated lesions, which it can be quite tricky to get your head around. This is another patient who had a double outlet right ventricle. We can see this is at 1:1 size, giving you an appreciation of how large the hearts that are being operated on actually are, and why it's so important to get this information, because even tiny errors can lead to very different results. Here we see another patient. This is a model which is made of a nice soft material, which allows our surgeons to cut into it and really appreciate where all the structures of the heart are before going for the operation. And finally, we have an example here where we have printed out our patch that we're planning to use to correct the lesion. So here we see I've taken it out. You can see where the hole in the heart is. And again, Branko is going to tell you a little bit more about how we use these patches. I'll just kind of hand over to Saravanan, who's going to talk about how we implemented this in our centre.
Okay, good afternoon, everybody. Thanks for joining us into this webinar, and thanks to Materialise for the invite, and thanks to my colleagues. So I think I would probably start off by saying the actual service within our congenital services started back in 2015. At that stage, we didn't have much of introduction about what was going within the hospital and the trust. And luckily, I think I would probably say for a success of any of this program, you need to find your end users to some extent. So, but luckily, my colleague at that time was a young surgeon, and we had a very young team who was quite keen with this idea as well. And given the fact when you have got an end user on board, it makes things much easier to start off with. So we started the service in 2015. At that stage, I think the primary impact was to try and improvise service to understand the anatomy so that we can provide better patient care. And the choices we had was about trying to use open source software versus commercial software. I think Matt has already alluded a lot about these, but I think given the fact the amount of bureaucracy involved within NHS, we need something which is clearly approved for medical use. And there are many open source softwares which are reasonably good, but again, when it comes to interface and usability, I think our choice at that stage was clearly obvious, which is many hospitals were using Materialise at that time. So we started off with Materialise, I think 17 version, and at that stage, we were contemplating about training within the hospital versus outsourcing this to somebody else. But again, given the complexity of conditions which we treat and the models of delivery of these types of services in other hospitals, where kind of an engineer has to sit with a medic to actually tell what exactly these structures are, which one to exclude, which one to include, we felt it's far easier for us to train. And I think the training probably didn't take more than a few days. And once you're up and running, when you start doing this, it becomes kind of a second nature to you. And I think so we opted to do that. And then the funding was kind of a big challenge. We did approach all possible sources, as Matt has kind of listed upon before, but I think the first and easiest way to actually get funding was through our charities, who are quite forthcoming to actually support us. So we kind of funded it through that. And any software will be good only if there is an appropriate hardware which is bought around with. So we actually factored that in, and we actually invested on quite a nice, powerful system of a PC. And then the workflow started. I think how often we use in our clinical practice, I would say 80% of times our multidisciplinary team meetings would include a kind of a cross-sectional imaging or a three-dimensional imaging. And given the fact now we have got access to these type of visualization techniques with 3D softwares, we use it more and more often. And on an average, I would probably say on a month, we show segmented data for complex patients, say around 4 to 6 times. So I think given the fact that the success again relies on integrated working relationship, I think there are plenty of reasons why you should integrate, but here I think we had radiology to be on our board because from imaging reasons, they are the one who actually gives us the actual raw data. And then the segmentation process and end users as pediatric cardiac services, and obviously 3D printing lab where Matt and Graham were very, very approachable at that stage. So but I think by the time we started, we were kind of up and running. 3D lab had a beautiful printer. So we didn't have to send any models out, and we kind of started printing this within our hospital itself. Our workflow is, I think, once we have been posed with a clinical question, we choose the appropriate imaging techniques, and then we go through what Greg has just shown. We do the segmentation, and the majority of times, the reason our curve is not the biggest user in terms of 3D printing is because majority of times we stop with virtual modeling. And virtual modeling is when you actually show this data set in a kind of a three-dimensional view on a computer, where you can rotate, cut, see the anatomy in a much more detail. And I think there are certain occasions where we feel that, oh no, I think we should proceed further, and that's when we try to print 3D that actually to aid and help our kind of surgeons to understand the anatomy, or the cardiologist who's actually referred to clarify the anatomy. The 3D printing we kind of currently use more and more for complex patients, and also for printing 3D patches, which are usually sterilizable and things like that. Imaging techniques, I would not dwell on it unless otherwise people are too interested about asking questions on this, but I think this is the key. If you don't get this right, the entire process of your work model will be so difficult, because optimization of your imaging protocols is a key, and that where I think we got our radiology on board. So we don't want any region where it is flaring up with kind of contrast and other areas with no contrast, and then your segmentation takes much longer time. Nowadays, time is money, so you have to try and optimize every step. And we use variable amount of 3D acquisition techniques, either a CT or MR. Generally speaking, most of our scanners are quite powerful, so we use feed and wrap or sedation, because majority of times these patients are infant groups, and very rarely general anesthesia. And gated versus non-gated is a hugely debated topic, but if we are going down the route of printing and we want very precise measurements, we tend to gate usually for diastole, so that I think we get the measurements more precisely. And the bottom line, again, to probably reiterate, is that if you don't get a clean data, your life will be so difficult. So I think this is where I think in terms of when you talk about all these things, the first question is it worth it? That's what people ask. I think the first and foremost is we got team on board, so it was quite worth it anyway. But now, having shown this, we can see its educational value, and I think our surgeons take the models to counseling during pre-op sessions, and that actually helps patients, and patients do prefer this. And parents do prefer this to see what exactly the anatomy is. And this is all where I think from decision making, which is like maybe a clinical or an MDT process, to the fact that we're actually delivering what we call as a personalized medicine or a precision medicine, which means you plan each and everything kind of personalized to that patient's care. Cost versus benefit, I would probably say, and on average, a complex surgery in pediatric cardiology would on a tariff basis would go up to £22,000. I think this is kind of very complex, and we predominantly use this 3D printing for very complex anatomies. But I think if you even take down to the simplest of surgeries, we are still talking about ICU stay, imaging, so much of people involved. So on an average, cardiac surgery is going to easily cost £10,000 to £20,000. But when you actually factor that into a one-off cost or a kind of a subscription-based cost for the software, it actually becomes negligible in terms of what you are actually spending for that patient's care. And that actually, I would probably say that the benefit it adds to the patient care is much more when you actually understand about the cost. So back to focus, I would probably say imaging is key. I think for us, we have taken over the imaging as well as a part of it, because me and Greg work in cross-sectional imaging. And I think radiology was quite supportive of this. I think that is another integration you could do if you want your program to be successful. And training to use the software, again, I think we are now have to find trainees who can probably help us out, because our workload is slowly going up, given the fact people see the benefits out of it. Collaborative working, as Matt has alluded to, is use what's available in your hospital before looking for avenues outside. And by integrating, you can make the process cheaper. And I think that's what we did with 3D printing, at least within our facility. And audit your activities, then you can get some more financial support. So with this is my kind of last slide. I think now we have successfully demonstrated to our trust that this program works, and Trust has happily agreed to fund us for another 5 years. And that is kind of a pooling as well, because we went together with Matt and Graham to say this is a kind of a combined program which will actually put the Trust's value higher up in terms of advancement in medicine. And our new goals are plenty. I think it's about time, investment, and how you can take it. We have been already approached by postmortem specimen laboratory to say, can we scan and print this so that it is non-demolishable? We are planning to think about teaching libraries. We are trying to think about computational fluid dynamics, which is possibility. And I think there are hospitals which are moving with the data set like holograms, where surgeons don't have to touch the model and can move the specimen to see in theaters, or you can use VR equipment to walk into the heart. So, and then the last icing on the cake would be a bioprinting. So the potentials are numerous. Establish your own working group so that I think this is, because when one person with expertise leaves, it's not going to stop the program. And network with other centers and publish your work. And that is the only way you can sustain your practice. Thank you.
Hello, everyone. My name is Branko Mimic. I'm a congenital cardiac surgeon in Glenton Hospital. I have no conflict of interest, although the company's name is actually the same as my surname, but I don't own this company. Yeah. So I'm going to talk a little bit about how me as a surgeon can use all this 3D modeling and 3D printing in everyday practice. And I really, as an end user, I'm really grateful that we started this program, and I'm thankful for that Greg and Saravanan actually introduced this to our department. So as we already mentioned, there is a huge variety of congenital cardiac lesions, and some of them are very complex. And actually, I can say that there is no two completely identical anatomy. And that's why it's really important to understand and fully appreciate all structures, especially when we deal with complex intracardiac and extracardiac anatomy. So this is actually quite important for surgeons to know all structures and relationships and special orientations of great vessels and intracardiac structures before going for surgery. And also it is well known that even the small changes in anatomy can affect hemodynamics significantly. As I already mentioned, this is particularly important when we deal with challenging intracardiac anatomy. Greg already mentioned that this is double outlet right ventricle is an example of very sometimes challenging pathology, with especially when we have a small VSD, non-committed VSD to the outlet. When we deal with common arterial trunk, which entirely comes from the right ventricle with the small VSD, or aortic stenosis atresia with VSD. As we already mentioned, the good thing is that with the 3D printing, that we can have a model with the different scales. Usually we use the 1:1, but if the heart is really small, for example, in neonates and infants, we can increase the size and use the 2:1 or 3:1 scale models, which can make our life easier. Now, I think that the best way is just I will go through a few examples how we use 3D models and 3D printing and patches that we can print in advance before surgery, how we can use this in theater and how this can make our surgical thinking easier. So the first example is a patient with double outlet right ventricle malpose great vessel, which means that the aorta is anterior, pulmonary artery is posterior, and they are entirely coming from the right side, and there is a VSD which connects the left and right ventricle. This patient already had a previous surgery, pulmonary artery bending and atrial septectomy, and then came for the final complete repair. As you can see on this model, we can appreciate all structures. We can see that the both vessels coming from the right side. We can look at the VSD position and the size of the VSD, relationship of the VSD to the great vessels and the tricuspid valve. Also, we can look and appreciate the size and volume of the right ventricle and what would happen with the right ventricle when we put a patch. There is also a patch that we can print before surgery. As you can see, this patch is not flat, is quite curved. So, and it fits perfectly well. And we use this patch to septate the right and left side of the heart in order to create a normal circulation. This patch can be created by material which we can sterilize and then use in theater direct, but not implant into the heart. But also, as you can see here, so as I mentioned, the patch is not flat; it's quite curved. So usually we use this template, and then we use the tubes or cylinders to create and fashion the patch that we need in theater. And we can know exactly the size of the cylinder and tube that we are going to use in theater. So, which also makes our surgical procedure easier and faster. This is the short video of how we use this 3D printed patch template in theater. Then we use this template to actually trim and fashion our actual patch that we are going then to implant inside the heart and divide the left and side heart and commit the left ventricle to the neo-aorta. As you can see, we use this Gore-Tex tube because it's curved and give us exactly the shape and of the patch that we need. And the size is this is the actual size of the patch that we are using. Of course, it's important to mark the sides and edges and actually angles of the patch in the appropriate way in order to avoid any confusion. And then we can use this patch and implant it and divide the left and right side. So the surgery that we did in this particular case was a double outer right ventricle repair. So we did a switch operation by changing and swap the position of the great vessels of the aorta and the pulmonary artery. And then by using this patch, which was anchored with surgical stitches, we divided the left and right side and committed the left ventricle to the neo-aorta. And also we did the Lecomte maneuver by putting the pulmonary artery in front of the aorta. This is the second patient, the second example that also we used this printed patch model that then we implanted inside the heart. This patient had interrupted aortic arch, aortic stenosis, ventricle septal defect, and previous surgery, Norwood type procedure, which is, I would say, quite complex procedure. And then final complete repair was Rostelli type procedure, which I already described, consists of dividing the left and right side and committed the left ventricle to the neo-aorta. This is also an example that when you can appreciate how we can use these printed patches and the templates. Sometimes if we cannot sterilize, or if we don't sterilize patch, we can just put the patch in the transparent plastic bag and then use the template to create our patch in the theater. And then patch fits perfectly well inside the heart. We don't need to trim the patch during the surgery, so that means that first of all, we can do much more precise surgery with a better outcome, and also sometimes we can say that it can save our time and make the cross-clamp time and cardiopulmonary bypass time shorter. So at the end, I would more or less repeat what we already said, that it's 3D printing really benefit our service a lot. We can counsel our patients and parents. We can show detailed surgical plan. Then we can visualize surgery in advance. We can go through the surgical steps before surgery, which actually can boost our confidence. As this is particularly important if you're a young surgeon, if you don't have too much experience, especially doing complex cases. So you can visualize the surgical steps before surgery. You can use this, this can make the surgery shorter, shorter cross-clamp time. Also, it improves learning curve and make the learning curve shorter. We can use the models for teaching and training purposes. And at the end, we will, in the future, we can start using the biomaterials which we can directly implant it in our patients. Thank you very much for listening and for your attention. At the end, I would like just to thank the East Midlands Congenital Heart Center, Matt and Graham, Radiology Department, and the Simone Spegerin, who actually was a surgeon who moved to Evelina Hospital, but he was the one who was really enthusiastic, and he started using these 3D models and as the first surgeon in this center. Thank you.
So thank you very much for that previous presentation from the Glenfield Hospital team. I think it's incredible to see those amazingly tiny pediatric hearts and just the intricacy of those and challenging cases that you encounter there. It's just amazing to see. So thank you for sharing those images and also, you know, discussing how you've implemented that technology for really improving your patients. So I'd like to start with the Q&A session. We've had one question in so far. What kind of printer and material did you use for printing the patch template? Who would like to answer that?
Do you want me to answer that, Emma?
Okay, lovely. Thank you, Matt.
The material for the hearts is a material called Agilus, which you can mix with a material called Vero, so you can change the sort of firmness of it, a bit like you can change a silicon rubber. You can do it in different shore hardnesses. We tend to do it in about an 85 shore for the actual hearts. The patches, we tend to print them one in each material, so they get one in Vero, which is a white hard material that cannot be autoclaved. Then we print them one in the soft material like the heart, which again cannot be autoclaved, but is quite soft and malleable. And then we print them another one which can be autoclaved, which is a material called Med 610, and that can be autoclaved, and that's quite a hard material. So that's why they had to use that. Sometimes you see them putting it in the plastic bag because that's the soft material they can actually squash down, whereas the hard material that's autoclavable hasn't really got too much flex in it. Yeah.
Okay. Perfect. Thank you for that
question.
I will let the person that asked it ask any more information in the chat window if they'd like further clarification. But thank you for that, Matt.
Okay.
We have another question regarding titanium implants. What type of manufacturing process does your chosen external company use for the PSI? Is it something that you have a choice over? And if so, why is this chosen over other manufacturing techniques?
The external company that we use is Renishaw. and it's like a fusion bed process. So it's a bit like yeah, built up on a bed of I'm trying to think what it is now. Yeah, it's printed titanium. It's not milled. They're printed. They're 3D printed in titanium.
Okay, thank you for that. Hopefully that answered that question.
Yeah, it's lasers. That's the word I was looking for. Laser
sintered. Yes. Perfect. I've got a question actually, probably for the Glenfield team, just regarding accuracy of models, because for me it was really profound seeing how small those hearts were in those intraoperative videos. Have you any kind of discrepancy between the model or the patches not fitting that patient's anatomy? What's your experience with that?
Yeah, I can answer this. Actually, in terms of anatomy, I have never experienced any discrepancy. So the size of patches, we don't use this quite often, but every time when I use these patches, they fit perfectly well. So although the heart looks really small, we are not talking about microns or 1 millimeter. So there is even if you've got a 1 millimeter discrepancy, this is not a big deal. But more or less, I have never need to trim the patch a lot or actually at all, and it fits perfectly well. So it worked very well.
I think also this is where the reverse validation step that we go through, I think, is really important. And also this is to do with the importance of getting very clear data. We're very lucky that we have a CT scan which can acquire pictures very fast, meaning we get very, very good definition between the blood and the actual heart muscle, the myocardium, and therefore we're very confident in that data. When we reverse validate the model that we create against that original data, we can be 100% sure that we're following all the contours of the heart as precisely as we can. I think there's also been some people who have studied this in the printed models versus real life, and they found that they maintain a very, very high level of accuracy within 1 millimeter.
That's true. I think the last thing again, at least for the patches side of things, again, I think this is where the integrated workflow comes into play, or collaborating comes into play. I think when we create these patches, we always get the surgeons in our room to say where the stitches go. So we actually, when we create the patch, we know exactly how big it has to be. Again, as Greg alluded to, there are many studies which is lots of agreements about real life measurements versus printed models.
Yeah, I think in terms of the printer accuracy, I think we're somewhere in the region of something like 17 to 24 microns. So it is meant to be a highly accurate printer. If that gives you any more clarification.
Actually, the accuracy of the patch is a little bit different, because this is the patch is we print the patch, but this depends on how we actually imagine the patch and what exactly where we want to put our stitches, and also sometimes depends whether we want to enlarge the BSD. So so the accuracy of the size of the patch and the shape of the patch is more related to our planning and where we how we draw the line with our cardiologists and on the 3D model on the computer, and then so it depends not only on printing, but it depends on how we actually want this patch to look like.
Okay, perfect. Thank you for clarifying. I've got another question. What printer and what material do you use for the 3D printed heart models?
The printer that we've got is Eden 350 Connex 3. and we use the combination of Vero White and Agilis to print the hearts. So it gives you a sort of fairly softish material. And we have got the facility with our printer, because it prints in different materials. We can change the consistency of that material. So we can make it firmer or we can make it softer.
Okay.
Yeah, we've tried a couple of different materials. We've tried printing some out in a hard material, which I think probably gives you slightly crisper detail. However, it doesn't feel quite right for looking at. And I think the surgeons appreciate being able to sort of bend things a little bit, move things out of the way, and get the little feel. And you can cut into it. So, for example, if you have a closed structure, you can just get a pair of scissors out and cut through it to see exactly what's inside. So that's why we like the soft material for that.
Yeah, it's easily workable, isn't it, the soft material, in terms of trimming and adjusting, so you can have a look at things.
I think in terms of if we're planning on teaching models, we may think about putting that in a hard material, because I suspect they probably have a slightly longer shelf life.
Yeah, the soft materials do tend to degenerate after a period of time, depending on how much handling and stuff they've experienced.
Yeah.
Mm-hmm. Okay, thank you for that. So the questions are coming in. We use Med 610 clear for orthognathic wafers. I thought it could not be sterilized. Can it also be used for cutting guides, and have you used it for this? That's Med 610.
Yeah, all our cutting guides are done in Med 610,
Okay.
as well as our orthognathic wafers, because again it can be sterilized.
Okay, and how long are you able to leave the Med 610 in contact with the patient in regards to the patches?
In regards to the cutting guide, you mean?
No, in regards to the patches. So two separate questions, one related to orthognathic wafers and the cutting guides. And then how long are you able to leave the Med 610 in contact with patient with regards to patches, but you don't, I guess, use that material for patches?
Patches aren't used to go in the patient at all.
No, okay.
We use just as a template. We don't. There is no contact between this material and patients.
Okay.
Yeah, you can put Med 610 onto periosteum and some soft tissue for up to 24 hours, but I think that's the limit.
Right. Okay. Thank you. Has anybody got any more questions they want to add? Because I know we're overrunning slightly, but I'm happy to keep it open for another couple of minutes if there are any other questions. Okay, I've got one more question regarding Med 610. Is there a limit to how long Med 610 for a mandible cutting guide? I'm not quite sure.
Is there a limit to what? How long it can go on the bone for, or the periosteum for?
I guess so. Yeah, there's not a huge amount of information here. Just says how long is it? Is there a limit to how long Med 610 can stay for a mandible cutting guide? So I'm assuming from that how long it will stay on the bone.
Yeah, they say up to 24 hours, but I mean, yeah, but normally we have two teams, one operating on the leg and one operating on the mandible or the maxilla. So our cutting guides are not normally left on the patient, I would say, longer than about 15-20 minutes max, I would say. But I know there is paperwork that says it can stay on for up to 24 hours.
Okay. Perfect. Thank you for clarifying that.
I've got a question. It's I guess it can be answered by both the Glenfield team and the MaxFax team. With regards to setting up this multidisciplinary 3D planning service, let's say for a new lab in another hospital or for a new hospital, what do you think are the key factors? Like Sharon, like you mentioned, establish a working group. What do you think are the key factors in approaching that whole multidisciplinary concept?
I think I probably the important thing I would say is again, from our perspective, there was a need which arose, and we wanted to tackle that need, and that was how our services started to develop. And then you can probably see how many other people are in similar positions. In terms of collaborating and making a working relationship, I think it's probably quite individualized in terms of which institute you're working. At least from a congenital perspective, I would probably say I think exploring within your hospitals, I think like us for Matt and Graham, when we found them, they are have got similar interests. It was quite interesting, and it was quite easy to set up that workflow. Otherwise, you can probably think about having a network collaboration where you can pool your funding to think about investing on these type of softwares and 3D printers. So it's quite slightly individualized. That's what I would say about what your needs are.
Yeah, I think first you have to find what your need is, and the need here was the maxillofacial team wanted to start doing patient-specific surgeries with the use of cutting guides and things like that, and they wanted to do it in-house. So then we needed a driving force, which was pretty much me and one of the old consultants that took it upon ourselves to keep badgering away at the hospital till they submitted, really. But I remember coming up to Glenfield and seeing the Mimic software and Simone showing me quickly how to threshold something, and I just thought, I'm never going to learn this. But with time and patience, it's not quite as tricky as you might think at first. So to anyone venturing into this, I would say stick with it. You will get there. It is a very steep learning curve, but a very worthwhile learning curve, especially when you see the smiles on your patients' faces.
Perfect. Yeah, I really like that. So yeah, indeed. Thanks for the answers both.
I think the one thing which I would probably add in this context is one of our network hospitals who also practices congenital heart surgery has approached us because they know our work, and that's how you establish and make your work worthwhile. Now I think once we started printing anatomical specimens and for teaching, that's going to spread to trainees, and trainees are going to take to wherever they take consultancy. Yeah. So that's how you spread the word. So it's like an effect which takes on itself.
Indeed, of course. Yeah, makes sense.
Even our senior consultants who are never used to 3D printing now are asking for 3D printing, and that tells itself.
Indeed, perfect. Yeah.
Kevin, from my point of view, it was great being able to contact you regarding anything technical, and also peers, Juliet Stoke and people like that have been very forthcoming with their information. So it's really about, how are you going to learn how to create cutting guides in 3matics? We could mimic ProPlan, but that was the steep learning curve. So that was really good that you're forthcoming, and other colleagues have been as well. So that's from my point of view, that's what I would say.
That's perfect. That sounds really good. Thanks, Graham.
Okay, well, thank you again to all of our clinical faculty who've been involved in this webinar today. I think we don't have any other questions. So the recording of this webinar will be available on our website, and I'm going to close this webinar session for today. But once again, thank you to everybody who was presenting some really fascinating content, and I hope it was useful for the delegates that registered. Thank you very much.
Thank you.
Thank you.